Thank you. Thank you, Dr. Gaganti. First of all, I would like to thank Professor Arjundas and Professor Velu Murugendran, the two doyens of neurology, for inviting me for this neuro update. And it's an honor to be part of this event. And thanks also to Dr. Deepak and Dr. Nadirajan and Dr. Meenakshi Sundaram for this opportunity. It's in fact an honor and pleasure to invite Dr. Jose Billa, who is the Professor and Chair, Department of Neurology, Loyola University Stitch School of Medicine, and the Loyola University Medical Center, Maywood, to give a talk on update on CADASIL. We all know that CADASIL actually is one of the most common monogenic disorder, and it is one of the disorders where we always suspect in patients with young stroke or young onset dementia. And we also know that there has been a lot of recent advances that has happened with regard to the pathogenesis and also with regard to the genetics regarding this. And there is always this concern as a clinician when a patient comes with a young stroke or a young dementia, differentiating this CADASIL from other sporadic small vessel disease, and also even rarely you may even mistake it for a multiple sclerosis. It would be a great honor to hear from Dr. Jose Billa on CADASIL. Welcome, and over to you, Dr. Billa.
Good morning or good evening. Thank you very much for your kind introduction. Professors Arjundas, Murugendran, Meenakshi Sundaram, Professor Singh, and Professor Sailaja, organizers of the 2023 Chennai Neurological Update, colleagues, I am delighted to be with you this Sunday in early January, and honored to share the podium with Professor Dawson, as well as has been a true honor to have been invited to participate in the case discussions that will follow my presentation. The aim of my 40-minute presentation is to provide a quick, clinically oriented overview of CADASIL, the most prevalent monogenic hereditary cerebral small vessel disease and the most common genetic cause of stroke and dementia in adults.
Sir, your PPT is not visible, sir.
I'm sorry?
Your PPT is not visible, sir. Come to the Zoom application and click the share screen, sir.
The share screen here?
Yes, sir. Yes. Yes.
All right. What about now?
Yes, sir. Perfect, sir.
Thank you. My apologies. These are my financial disclosures. None, really. And as you all know, the field of stroke genetics is fascinating, intriguing, ever expanding, and we all are aware that stroke is a very complex genetic disorder with a heterogeneous phenotype, and moreover, it encompasses genetics of atherosclerosis, leukoariosis, the genetics of Mendelian and mitochondrial disorders associated with stroke, where CADASIL is one of the many areas that will be the topic of discussion. But also it goes further to the genetics of aneurysms, the genetics of intracerebral hemorrhage, and the genetics of cerebrovascular malformations. So today's presentation is a real fragment of this fascinating field. So allow me to share a pre-test question that you don't need to answer now. We can get the answer or the best answer at the end of my presentation. Which of the following disorders, besides CADASIL, has an autosomal dominant mode of inheritance? Is it Milas? Is it homozygous homocystinuria? Is it HCBR or Hearns? Is it Anderson-Fabry's disease, or is it CADASIL? And here I listed the field of biomarkers that is ever expanding. And in this slide, I am just showing conventional structural biomarkers for small vessel disease. On the far left, an MRI showing white matter hyperintensities. On the middle, lacunar lesions. And on the far right, cerebral microbleeds. So there are others, obvious, but these are some that all of us have access in practice. And when we go to the field of the monogenic disorders causing small vessel disease, in addition to CADASIL, there are many others. Obviously, they are not as frequent, including CADASIL, that stands for the cerebral, the autosomal recessive cerebral arteriopathy with subcortical infarcts and leukoencephalopathy. This is a condition that in Japan is known as Maeda syndrome, where there is intense arteriolosclerosis, but unlike CADASIL, is not associated with granular osmophilic deposition. And there are others where there is an added compromise of the kidneys, as well as aneurysms and muscle cramps, like in Hanna's disease. But I am going to refer only to CADASIL. So it is possible that it was Van Bogart in 1955 that actually provided us with the first description of what we now know as CADASIL. And he referred to a subcortical encephalopathy of Binswanger type of rapid course. Actually, the title of his presentation or his article was Binswanger disease with a rapid course in two sisters. The condition was known also as hereditary multi-infarct dementia, chronic familial vascular encephalopathy, familial subcortical dementia, and then in 1991, Tournier Lasserve and colleagues from France described an autosomal dominant syndrome, they call it a syndrome, with stroke-like episodes and leukoencephalopathy among 45 individuals of a single family. And the French colleagues reported stroke-like episodes, TIAs, minor or major strokes that occur in the 4th to 6th decade of life, and other symptoms which included migraine with or without aura, dementia, epileptic seizures, and also, although very rare, hearing loss. So how prevalent is CADASIL? And perhaps the answer is just an estimate, because it is conceivable that the disease is underdiagnosed, or, as I'll show you, misdiagnosed. But it is rare, but it is estimated that perhaps 2 to 5 per 100,000 people may have CADASIL, and certainly the disease is seen worldwide. There is a worldwide occurrence affecting all races, affecting various ethnic groups. Men and women are affected in equal numbers, but we have learned that genotypically and phenotypically, this is a diverse condition. And to date, I needed to, and my apologies, I should have upgraded this slide. Today, more than 95% of cases, perhaps around 98% of cases, have been reported from at least 230 different mutations that cluster in exons 2 to 23 of the Notch3 gene. And the mutations include single missense mutations, small in-frame deletions, and splice site mutations, among others. So, as we said before, CADASIL, that stands for cerebral arteriopathy, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, is the most common Mendelian form of small vessel disease, or the most common hereditary subcortical dementia. The onset is insidious, but usually the mean age of onset of symptoms is around 45 years. Some cases may occur earlier. And as I mentioned, it has been described all over the world. In Europe, in the Americas, in Asia, in Africa, and there is now increased medical recognition. And I believe that this is the first genetically proven CADASIL report from India, published in Journal of Stroke and Cerebrovascular Diseases in 2013. CADASIL, as we will see in a moment, is a non-atherosclerotic, non-congophilic angiopathy, where there is a granular degeneration of the media, mainly affecting cerebral arteries of small caliber. And by that I mean 20 to 200 micromillimeters in diameter. There is a characteristic granular electron-dense osmiophilic material that is attached to the vascular smooth muscle cells, not only of the cerebral vessels, but also that has been shown in extracerebral vessels. And for example, muscle, peripheral nerve, spinal cord, spleen, liver, heart, testes, etc., raising the possibility of actually a more generalized disease, although we still refer to the condition as a cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. And pathologically, there is diffuse myelin loss in the cerebral white matter, and characteristically, this diffuse white matter loss spares the U fibers. I'm going to now talk about some of the clinical features, because I think that the audience perhaps will benefit more from this type of approach rather than a more basic science approach. So CADASIL, oftentimes patients with CADASIL may present with migraine with aura or without aura, although characteristically they have migraine with aura. Transient ischemic attacks or subcortical ischemic strokes that may be recurrent, dementia, mood disturbances, and a variety of miscellaneous manifestations that we will talk as the presentation evolves. It appears that migraine with aura occurs earliest in women than in men, and in about the strokes, typically, at least in 2/3 of the cases, the clinical presentation is with the classical, the most common lacunar syndromes. By that, I mean pure motor hemiparesis, pure sensory stroke, sensory motor stroke, or ataxic hemiparesis. Those lacunar infarcts tend to affect mainly the supratentorial structures, except for the pons when we refer to the infratentorial structures. So keep in mind that when it comes to lacunar infarctions in patients with CADASIL, and this is just an overview, it's not an absolute, most infratentorial regions, except for the pons, are spared. The cerebellum is spared, and supratentorially, the corpus callosum is spared. The hemorrhages that are described in CADASIL are relatively uncommon. However, microbleeds are more common, and they have been estimated in about 1/3 to 2/3 of cases. And that is very relevant when it comes to the decision in case that you are confronted with a patient who has CADASIL and now presents with an acute ischemic stroke, in regards to the safety or lack thereof administering it a thrombolytic agent. When it comes to microbleeds, they are more common in the thalamus, in the basal ganglia, in the cortico-subcortical junction. But again, overall parenchymal brain hemorrhages are relatively uncommon, although I'll show you some examples. Mood disturbances are quite common as the disease evolves, with depression, apathy, manic episodes. With further progression of the condition, patients exhibit manifestations of dementia, not uncommonly associated with upper motor neuron signs, pseudovalvular palsy, gait impairment, spastic tetraparesis, and they may have urinary incontinence. Seizures, whether focal or generalized, have been reported in about 6 to 10% of patients. Status epilepticus, as we will see, is rather uncommon. Women, as I mentioned earlier, are more likely to present with migraine with aura, while men are more likely to present with stroke. Again, this is just an overall observation, it's not an absolute. In this case, this is an elegant study published in 2004 in Brain from the United Kingdom with 127 CADASIL cases from 65 families. What the authors noted was that although there is a highly stereotypic nature of the mutations causing CADASIL, the clinical phenotype, and I must say also the genotype, are quite variable. But what they observed was that besides the obvious that smoking increases the risk of stroke, they observed that homocysteine levels increase the risk of migraine. So this is something that you may wish to consider in your practice when you are evaluating CADASIL suspect patients or those that you have an established diagnosis. Allow me to share with you the video. It's about 2 minutes of one of my patients with genetically proven CADASIL, describing one of his recent events. He is a gentleman originally from Egypt.
Actually, we don't have the volume.
You don't have the volume?
So, sir, on the top, there is a option called more option. Click that, and there is option share audio, computer sound.
You are asking me to do that?
Yes, sir. Yes, sir. If you do that, we'll hear the video voice. On the top, there is a near the stop screen. On last, there is a click for more option. When you click the more option, there is a called share sound.
Let me see here. Share sound. My apologies.
Yes. Okay,
My
sir.
apologies. Let me go back, okay? My apologies.
But the numbness of the left hand. Last night at midnight, I was sleeping at my left
Is
side
it okay
of
now?
my body.
Yes, sir.
This,
Thank you.
and I wake up. Oh, something! I have numbness in my left hand, and this numbness started with the left side of my face, both at the same time. Start numbness, but the numbness of the left hand go down like this, go down on the left side of my body, go down, still go down of my body, left side of my body, still go down of my leg, go down, go my foot to till my toe, go down.
How long did it take from the hand to your foot? How long, how much time?
About 10 minutes or so, no, not more than.
Did you have any weakness?
Yes.
And when you got better,
Yes.
did it start in any specific area? How did you get better? What part got better first?
Once I felt it is numbness, so I took my medicine. So it start with my hand the same. Start with my hand first, and recovery is start go down. Recovery go down. Recovery go down. Recovery in order go down till my foot.
How long did the entire episode last?
It's take to 17, 20 minutes. Everything is gone, is good. Yeah.
Did you have any headaches?
After that,
No problem.
no problem.
Thank you very much.
I like.
So he had a very characteristic transient focal neurological deficit with a march, a slow march, beginning in the hand and face and resolving in the same way that it started, lasting about 20 minutes. Certainly this is not a TIA, it was not a focal sensory seizure. This is a non-congophilic process. It's not an amyloid spell. This patient had a migrainous event. And Chabria and collaborators in France published this excellent review in 2009 Lancet, where they show nicely over the span of the years that in general, the early manifestation in patients with CADASIL is migraine with aura. At that time, you begin to see changes on imaging studies with T2 white matter abnormalities, subcortical ischemic strokes that can be recurrent, followed by mood disturbances, apathy, motor disability evolving to a subcortical type dementia with executive dysfunction. And more recently, when issues about the survival of these patients, it has been shown in some studies that because of this variable phenotype and genotype, that individuals with epidermal growth factor 1 to 6 variants have earlier stroke onset, higher brain lesion load, and lower survival rate than those that have the 7 to 34 variants. So these are the general clinical manifestations in about 100 patients with CADASIL published by Diggans and collaborators approximately 3 decades ago. And once again, you see that the most frequent initial manifestation is migraine, followed by other brain ischemic manifestations, TIAs, or subcortical ischemic strokes. The nature of the migraine with aura, the aura typically is visual or sensory, like the example that I show you with my patient, is one of the earliest clinical manifestations in early or mid-adulthood. Status migrainosus is rare, but sometimes the aura can be protracted. One could argue that our patient probably had a little bit of a protracted aura. Generally speaking, the aura can be either typical or atypical. For example, the patients can have aura without headache. Our patient didn't have headache. By the way, the medication he used was Diamox, acetazolamide. Sometimes there may be hemiplegic auras, or what now is known migraine with brainstem aura that previously was called basilar migraine, or it could be a prolonged aura, or it can be an acute onset aura. Regarding the subcortical ischemic strokes, the mean age of occurrence is in the 4th to 5th decade. The characteristic syndromes are the conventional, typical, the most frequent lacunar syndromes, although Fisher described more than 20 of them. The most common remain the pure motor hemiparesis, the pure sensory stroke, the dysarthria clumsy hand syndrome, the ataxic hemiparesis, and the sensory motor stroke. And some of these patients actually, may have developed a lower body Parkinsonism, a vascular Parkinsonism, or a pseudo-valvar state. Large artery territorial infarcts are exceedingly rare. That is something that we need to take into consideration. So these are some examples of patients from my clinic with CADASIL who had subcortical ischemic strokes. Some had other associated findings. And this is a patient that came to see me with the following history. So allow me to share this with you and ask you the question whether or not you would consider that he probably has CADASIL. 42-year-old, history of migraines with aura, had sudden onset of a severe migraine headache, dizziness, veering to the right, and dry hips. He did not recall having any neck manipulations or cervical spine trauma. For the past 2 or 3 years prior to the consultation, he had frequent episodes of migraines with visual auras, had at least two episodes of headaches associated with sexual activity, pre-orgasmic, non-postural, occurring 3 months prior to the index event. His father was disabled at age 67, believed to have CADASIL, although genetics testing was never done. And he has an older brother, age 44. He was diagnosed with multiple sclerosis, but subsequent genetic testing showed that actually he had CADASIL. And he comes with this imaging. On the far left, you have the MRI showing an area of restricted diffusion involving medial and vermian branches in the territory of the posterior inferior cerebellar artery on the right. And you can see on the MRA the different caliber of the right vertebral artery. Does the patient have CADASIL or just happen to have a large vessel process that could have represented a dissection of the vertebral artery causing a pica territory infarction with sparing of the medulla oblongata? And actually his testing, including skin biopsy, genetic testing and skin biopsy were negative. So he had a family history of CADASIL, had a stroke, but did not have CADASIL. Regarding the dementia, typically these are patients who present with a predominantly frontal lobe dysfunction. They have features of executive dysfunction that is very characteristic. And there have been some elegant studies that demonstrate that this impairment of executive function occurs early on with a decline in attention and memory. And unlike patients with Alzheimer's disease, retrieval is improved with cues, with relative preservation of encoding processes in episodic memory. But not surprisingly, in the late stages of the disease, there is impairment on multiple cognitive domains. Some other interesting studies have shown that in cases of CADASIL, unlike Alzheimer's disease, where you have early changes in hippocampal and entorhinal and temporal cortices, the greatest cholinergic loss in these patients involves the posterior parietal, the dorsal frontal, and occipital cortices. Another important issue is the psychiatric disturbances, the mood disorders that are by far the highest frequency of these disorders. These are patients who also may present with a variety of other psychiatric manifestations, including anxiety, psychosis, adjustment disorders, behavioral and personality disorders, and not uncommonly, drug addiction or substance abuse, particularly alcohol. As I insinuated previously, the cognitive decline is characterized by a prefrontal lobe dysfunction with impaired executive and organizing abilities. The mental abilities slow down. The patients exhibit poor concentration, slowing of motor function, but as stated earlier, the memory disturbances, unlike the typical phenotype of patients with Alzheimer's dementia, the memory disturbances are less prominent. In regards to correlation between stroke and other risk factors, it has been shown that high blood pressure and past years of cigarette smoking are associated with an increased risk of stroke. That risk of stroke also enhances the risk for both dementia and disability. And when it comes to the burden of the lacunar lesions, they correlate with disability and cognitive impairment. Allow me to say a few words about other less common manifestations. Epileptic seizures. I want to say one or two words about what is known as CADASIL coma. I mentioned earlier about hemorrhages. I will say a couple of words about lobar hemorrhages and touched upon some of the observed retinal abnormalities in these patients. In 2 to 10% of patients with CADASIL, they may have seizures. Those can be focal or generalized, but status epilepticus is rare. The same is true for status migrainosus. So remember, migraine is common, status migrainosus is not. Epileptic seizures are not rare, but status epilepticus is. CADASIL coma refers to an acute self-limited encephalopathy that may be recurrent, that is often misdiagnosed as an acute encephalitis, whether viral or autoimmune or a toxic metabolic encephalopathy, typically presenting with confusion, with headaches, with seizure, and even pyrexia, and it may be triggered by cerebral angiography. And that is very important, as I will discuss later, that angiography, conventional angiography, is not only not indicated in these patients, but also can be harmful for these patients. So it is very important that that be taken into consideration. Some have recommended acetazolamide in the management of patients with this type of disorder. The cerebral hemorrhages, the true parenchymatous intracerebral hemorrhages are rare, unlike the microbleeds that are more common that we touched upon. These are hemorrhages that often develop in relationship to the number of microbleeds, and some have correlated the risk of these hemorrhages with uncontrolled blood pressure or uncontrolled blood sugar. These are some patients of mine who had brain hemorrhages, patients with CADASIL with brain hemorrhages, different size, different clinical manifestations. And obviously, when there is a lobar location, you have to wonder, are they due to CADASIL, or could the patient have something else, like could be cerebral amyloid angiopathy? And these are some early reports of CADASIL patients with hemorrhagic strokes. And if you were to look at the far right, none of these patients were on antithrombotic therapy, and basically most of them, except for one, have high blood pressure, and a few had diabetes and hypercholesterolemia. And this article from Brain correlates the cerebral microbleeds in CADASIL with blood pressure and hemoglobin A1C, that independently, the lack of control of the blood pressure and the blood sugar independently predict the risk of cerebral microbleeds in CADASIL patients. When it comes to retinal abnormalities, there are descriptions of AV nicking or arteriolar narrowing and bilateral peripapillary arteriolar sheathing, but certainly, at least to my knowledge, no evidence of retinal infarcts or vascular occlusions or hypoperfusion of affected vessels. So these are not patients who present with a central retinal artery occlusion or a branch retinal artery occlusion or an ischemic optic neuropathy. Interesting enough, although in the early observations in 1991, they reported a case of deafness, there are few cases of deafness reported in patients with CADASIL, sensory neural hearing loss. That obviously will include then in the differential diagnosis conditions like, let's say, Susak syndrome. Cranial nerve involvement, though, is other type of cranial nerve involvement is less common, and there are rare cases of spinal cord involvement, rare cases. I just shared with you one reference. They are isolated cases, and actually the patient that I show you the video, he has also a myelopathy. To my knowledge, no muscular manifestations, although these changes, the granular osmiophilic changes, have been demonstrated in muscle tissue. The MRI features are, I am certain, well known to all of you, but allow me to refresh your memory. There are widespread changes on T2 weighted and FLAIR images involving the white matter. These are non-enhancing hyperintensities. Therefore, this is a leukoencephalopathy affecting the periventricular white matter, the centrum semiovale, and other structures. There is a predilection for the anterior pole of the temporal lobes, as well as the extreme and external capsule. The brainstem usually is the central pons. The maybe widening of the Virchow-Robin spaces, and in about 1/3 to half, as I discussed earlier, there may be microbleeds. And what is very important is that some of these abnormalities may be detected in the pre-symptomatic phase, as shown in the earlier paper by Chabriat and collaborators. This is a classical example of an MRI showing the symmetrical features, the involvement of the anterior aspect of the temporal poles bilaterally. And please note that also the external and extreme capsule are affected. Those will be unusual, highly unusual areas to be affected by the most common demyelinating process like multiple sclerosis. MRA, though, is typically normal, and if done, generally speaking, you will see a normal lumen of the lenticulostriate vessels. As I mentioned, cerebral angiography, conventional catheter cerebral angiography is not contributory to the diagnosis. And moreover, it can be associated with complications such as triggering CADASIL coma, worsening neurological deficits, increasing the risk of vasospasm, and it is contraindicated. It is contraindicated. And therefore, I personally tell my patients with CADASIL to wear a bracelet saying that they have CADASIL. And what happens is that as yet, CADASIL is not very well known by physicians. Unfortunately, it's not very well known by neurologists. And sometimes these are patients who end up in an emergency facility and they may be exposed to unnecessary risks. And in this original paper by the same group, Dickens and collaborators, they look at the angiographic complications among 16 patients with CADASIL. 11 out of 16 had neurological complications induced by angiography. Half were reversible, but it was permanent in 2, including aphasia, including seizures, including blindness, including strokes, including encephalopathy. Please don't do catheter cerebral angiography in these patients. The cerebrospinal fluid has been investigated. Some of these patients may have oligoclonal bands. Some may show discrete pleocytosis. Some studies have shown low levels of amyloid beta 42. In general, there are no changes in total tau or phosphorylated tau. And some researchers are showing interest in looking at other biomarkers like neurofilaments. When I discuss the pathology, I briefly mentioned that this is a systemic, non-amyloid, non-arteriosclerotic or atherosclerotic disease that affects the wall of small size artery of virtually all organs. So really, we are learning more and more that this is a systemic condition. There is fibrotic thickening of the cerebral and leptomeningeal arterioles usually without stenosis. And basically what happens is that this pathological process results in decreased cerebral perfusion and inability of these blood vessels to regulate. And that perhaps is the mechanism, although the mechanism is not completely understood. As I mentioned, there are periodic past positive granules, the granular osmophilic material on the arteriolar vascular smooth muscle cells, and that can be identified with electron microscopy on skin biopsies. And when a skin biopsy is done, generally speaking, the dermatopathologists will be looking at this in the border zone between the dermis and the upper cutis. But as I insinuated earlier, systemic disease, there are changes in the skin, spleen, liver, kidney, muscles, testes, and other vessels of different caliber. The U fibers are spare. Of the infratentorial structures, the pons is the one mainly affected with what is known as pontine rarefaction. Generally speaking, the changes in the hemispheric white matter is characterized by diffuse pallor, predominantly in the centrum, semiovale, and periventricular regions. And here you have the features and histopathology and electron microscopy of the granular osmophilic changes in electron microscopy. Now, the diagnosis is sometimes underdiagnosed or misdiagnosed, and it is obviously understandable. This is an unusual condition, but I think that it would be important to go through this differential diagnosis. Remember, Binswanger never described the pathology of what subsequently was known as Binswanger disease. That was Alzheimer's, stating that, well, this condition should be called Binswanger disease. We mentioned about cerebral amyloid angiopathy. MILAS sometimes can be in the differential diagnosis, mitochondrial disorder with stroke-like episodes that tend to affect the posterior regions of the brain in a non-vascular distribution. The recessive form CADASIL or Maeda syndrome with striking alopecia and spondylotic changes. In my experience and the experience of most, the most common misdiagnosis is with multiple sclerosis. Cerebral vasculitis may be part of the differential, including certain leukodystrophies like adrenoleukodystrophy, leukoencephalopathies of unknown cause, and in rare instances, even with Alzheimer's disease. This is one of my patients who had multiple lobar hemorrhages. As you can see, he has also extensive changes of the white matter. This patient had cerebral amyloid angiopathy. In this table, I'm trying to show the clues to the differential diagnosis between CADASIL and multiple sclerosis. This requires some caveats. Certainly, there is a stronger family history to support CADASIL. Migraine with aura will be in favor of CADASIL. Involvement of the anterior aspect of the temporal lobes, the temporal poles, external and extreme capsule will favor CADASIL. And symmetric and widespread lesions on MRI will favor CADASIL. Now, I mentioned about the spinal cord lesions. Obviously, spinal cord abnormalities will be much more common with multiple sclerosis than with CADASIL, but there have been some instances where spinal cord lesions have been described in CADASIL. I am including in this slide the current diagnostic test for CADASIL. And as you can see, you have genetic testing that, generally speaking, evaluate the most commonly affected exons, and those have the highest sensitivity and specificity. Then the immunohistochemistry in skin biopsies and the electron microscopy. And it is important also to know that what is the positive and negative predictive values of these tests. But in general, the gold standard remains the genetic testing, with the caveat that the general laboratories who are doing this are not studying all the exons, but the most commonly affected. Skin biopsy, interesting enough, allows not only a diagnosis in early stages, not only in symptomatic individuals, but also, probably more important, in asymptomatic individuals and offsprings not affected according to MRI criteria. So in the last few minutes, I am going to review for you something without much data, but I think that very practical, because you are taking care of these patients, and certainly the patients are asking these questions, or you may be consulted what to do next. First of all, you have to be very straightforward that at the present time, there is no proven therapy to influence the natural evolution of CADASIL. The value of antiplatelet agents in regards to secondary stroke prevention have never been tested, but there is, it could be logical to recommend them, with the caveat that sometimes aspirin can also be associated with microhemorrhages. Certainly there is no indication, and actually there is a contraindication for the use of anticoagulant therapy. Regarding the management of the migraines, triptans are not recommended, and ergo derivatives are not recommended. In regards to cognitive, mood, and psychiatric disturbances, there are some articles supporting the use of conventional cholinesterase inhibitors like donepezil, rivastigmine, galantamine, etc. The use of memantine, the use of antidepressants like selective serotonin reuptake inhibitors, obviously proper counseling and support and rehabilitation. L-arginine has been proposed by some. I mentioned earlier that there is a problem with autoregulation, and there is endothelial dysfunction in patients with CADASIL, and we know that L-arginine may improve endothelial dysfunction. Some use L-arginine. Likewise, acetazolamide improves cerebral hemodynamics. It has been recommended for some of these patients. I have prescribed acetazolamide to the patient that I show you on the video, and that is the medication that he took while having that episode. Not proven. Some studies show that donepezil may improve executive dysfunction. It has been recommended by some. The short-term use of statins has not been shown to be useful and therefore we don't use it unless there are other vascular risk factors. A common question is about management if these patients are going to have anesthesia. There is little information. Clearly, one would recommend to discontinue antiplatelets pre-op, to measure the electrolytes pre-op, particularly if the patients are on acetazolamide. Common sense will indicate to maintain normovolemia and mean arterial blood pressure within the ranges of autoregulation, the maintenance of normocapnia, the avoidance of the head down position, keeping in mind that volatile anesthetics decrease cerebral metabolism and increase cerebral blood flow. Peripheral nerve blocks for anesthesia wouldn't be a problem. And there should be theoretically a potential advantage of neuraxial anesthesia over general anesthesia, but I must confess that there is very limited data. So when I am asked this question, and actually that was a question asked to me about one of my patients a week ago, I share this slide with them with these two references. Now, I want to say a word or two about TPA. I didn't include a slide because the efficacy of TPA for the treatment of acute ischemic stroke in CADASIL is uncertain. This is the best we can say, that is uncertain, although no contraindication to TPA has been established for this specific population. Careful evaluation of prior microbleeds is critical. And that is another reason why I tell my patients to wear a bracelet, and I provide them with a way to contact me in case there is any question. It happened a couple of months ago with one of my patients that actually the question was whether or not tenecteplase would be safer. I don't think that we have enough data, or any data for that matter, but the symptoms resolved, so they didn't administer any thrombolysis. But this is an area for further research. Regarding the pre-test question and now the post-test, of those listed options, the condition that is also autosomal dominant besides CADASIL is HERNS and HCVR. And that takes me to my final slide, where I want to convey to you 10 take-home messages. Number one, CADASIL is the most frequent cause of hereditary ischemic small vessel disease of the brain in adults, is the most common hereditary subcortical vascular dementia. The molecular genetic testing for the Notch3 gene on chromosome 19 is what is required for the genetic diagnosis. Most of the mutations are missense mutations. The skin biopsy and immunostaining with Notch3 protein in the vessel wall is an alternative. The earliest clinical manifestation is migraines with aura. Please avoid catheter cerebral angiography. Avoid anticoagulants, whether vitamin K antagonists or direct oral anticoagulants. For the management of headaches, migraines, common analgesics, non-steroidal anti-inflammatory drugs, or acetazolamide is fine. Avoid triptans or ergot derivatives. Questionable, maybe questionable though, Donepezil may improve speed processing and executive dysfunction. And please be patient. These are patients who require patients and family members psychological support for them. And certainly there is ongoing research in this area. And I'll be happy to entertain any questions at your convenience. Thank you very much.
Thank you. Thank you, Dr. Billa. It was, in fact, an excellent overview of the clinical characteristics, diagnosis, and the management. And most importantly, bringing in very important clinical tips, which will be very useful for a practicing neurologist with regard to the diagnosis and also with regard to the management. First of all, I would just, there are a lot of questions which has come up. I would just like to ask 2 questions before I open to the floor. First is with regard to, you mentioned that there is a direct correlation between the cognitive dysfunction and the load of the lacunar infarcts. Is it only specific to the lacunar infarcts? Because we have had a few patients who are diagnosed, who had presented with stroke and proved to have CADASIL. They may be having a grade 3 small vessel fasciculus changes, but you find even after in a detailed cognitive testing, you don't see significant amount of cognitive dysfunction. So with regard to the white matter changes, do you think that there is no significant direct correlate with the cognitive dysfunction, or is it different?
No, I think that there is. But I was referring to a particular article or series of articles that make that kind of a correlation. But certainly, yeah, we see that particularly when they become very extensive and as the disease progresses, you can see that. And then there is this overlap because there are these superimposed mood and psychiatric abnormalities. Many of these patients have at that time pseudobulbar palsy and other features. Yes, indeed. Yeah, I would say so.
Second is with regard to the microbleeds. We tend to see a lot of patients with CADASIL having studied with microbleeds, but rarely we see they presenting with bleed compared to the other patients who have got significant load of microbleeds. What may be the reason for that?
Basically, yes, 1/3 to 50% or so of patients with CADASIL may have microbleeds. And obviously, we think on microbleeds and we are thinking on, is this due to a hypertensive microangiopathy, or these are microbleeds due to cerebral amyloid angiopathy? Obviously, CADASIL will be a player. I think that obviously, even when it comes to contraindications between quotes about the use of intravenous thrombolysis in patients with microbleeds, how many microbleeds are enough? But sometimes there are microbleeds that are not visualized by current MRI. So you are raising an important point that they may not have the parenchymatous hemorrhages as you see with the microbleeds associated with cerebral amyloid angiopathy. And many of these patients with cerebral amyloid angiopathy can have cortical siderosis and other risk factors. So yeah, I think that is an interesting observation. You are implying a different behavior, if you wish, in regards to risk of parenchymatous symptomatic hemorrhages. I think that is something that hopefully there is an ongoing consortium that hopefully will provide answers to many of these questions. The principal investigators are Dr. Jane Paulson at the University of Wisconsin in Madison, and Dr. Michael Geschwin at the University of California, San Francisco. where 12 academic medical centers in the United States will hopefully provide many answers to these fascinating patients.
So there are a few questions which are there. One is, in a patient with a CADASIL, if a patient comes with a lacunar infarct and it is a lacunar syndrome and already having a background of atherosclerotic disease, how sure are we, is it with regard to the CADASIL related stroke in that patient with a proven CADASIL? It's very difficult.
Yeah, well, first of all, lacunar syndromes not always are due to necessarily lacunar infarctions. They can be due to large vessel disease, they can be due to hemorrhages, they can be due to non-vascular conditions. The syndrome, is that right? Pure motor hemiparesis, for example. So obviously, not all lacunar infarctions are due to hypertensive arteriolosclerosis, lipohyalinosis. When C. Miller-Fisher describes the classical lacunar infarctions, not all of these patients have lipohyalinosis. Some of these patients have microatheromas in the ostium of a penetrating vessel. Some of them may have embolic mechanisms, etc. Yeah, I think that is very challenging. Oftentimes is more inference than definitive. So you use your best clinical judgment. I don't know how to answer that intriguing question, really.
So there is a question by Dr. Sunil Gajre. Why are ergot and triptans contraindicated in the headache of CADASIL?
Well, good question. The question is basically the risk of vasoconstriction, but I would say that most articles, there is an article that you can check in expert reviews in neurotherapeutics or expert review in therapeutics, reviewing this particular topic that lists the drugs that are not contraindicated and the drugs that are contraindicated. You know, in the United States, the use of ergots, I mean, I know that in the rest of the world, you may have some other ergot derivatives for the management of migraine, but we don't use them for a long number of years.
There is one more question by Dr. Partha. This is with regard to, you mentioned about the OCB in the CSF. Is there any role of steroids in CADASIL, thinking it's a vascular and an inflammatory combined pathogenesis?
No, not to my knowledge. This is a non-atherosclerotic, non-amyloid, and I will say non-inflammatory arteriopathy. So it's not a vasculitis, it's not an amyloid arteriopathy, and it's not an athero or arteriolosclerotic process.
So, Dr. Gagandeep, do you want to ask? There are a lot of questions in, so I think we won't be able to take all the questions.
We do have some time, so maybe all
It was
just a fascinating talk and so clinical.
Yes, yes.
If I can ask, in someone who presents with migraine with an aura, and presumably that's in the age group 10 to 20 years, are there any characteristics by which we can say that this is due to CADASIL and not the usual garden variety of migraine with aura?
To my knowledge, no. I think that the characteristics are very similar. So it will be when you say, well, there may be a family history of stroke or a family history of dementia or a family history of multiple sclerosis, and then you begin to be suspicious, and then you have an imaging study and say, oh, this is intriguing. I mean, there are changes in the temporal pulse and so on and so forth. But from a clinical phenotype, I would say no.
Thank you.
So there is a question by Dr. Balamurugan. What is the pathophysiology of migraine in CADASIL? Basically a vasculopathy, and why is conventional angiography harmful in CADASIL?
Okay, let me try to answer the second question. The second question first. I show you data from Ditkins and others about the risk. And I show you data about the so-called CADASIL coma. And there are some patients that may have an encephalopathic processes that occur in the context of CADASIL that they may be misdiagnosed as an autoimmune encephalitis or a viral encephalitis like herpes simplex and so on and so forth. So the intrinsic mechanism, I don't know, but certainly I wouldn't do it. The same is true would be catheter cerebral angiography in patients with a vascular type of Ehlers-Danlos that are at increased risk for carotid cavernous fistulas or dissections, etc. So we don't do it. In regards to the first question, I am always intrigued if somebody were to ask any of us, please define what is migraine. I don't think that we will be able to complete the sentence. So my answer is I don't know how to fully respond to your first question.
Thank you. One more question, we will end probably with that question. One is with regard to the case which you have shown, where there is a strong family history of CADASIL and the patient, the representative patient, had a cerebellar infarct which showed a right vertebral artery showing irregularity, suggesting probably it may be a large artery atherosclerosis. But there is definitely historically something background to suggest a CADASIL also in that patient. So do you think this stroke is clearly related to atherosclerosis and probably there is CADASIL is not a possibility in this patient? What was the white matter changes in this patient?
All right, so I think that I can answer this one for a change. If you look at, first of all, he had a territorial infarction in medial branches of pica, medial hemispheric branches, and also on vermian branches of the posterior inferior cerebellar artery territory on the right, with sparing of the medulla oblongata, so there was no Wallenberg syndrome associated with that. The caliber of the vertebral artery throughout its length was irregular. So it was not only the extracranial segment, but also the intracranial segment. Atherosclerotic processes in the posterior circulation will occur more common at the origin of the vertebral, at the junction of the vertebral with the basilar. And in this case, it was throughout. So I thought that it was most likely dissection rather than atherosclerotic. But in answer to your question, the remainder of the MRI did not have any overwhelming features in the white matter. It was the family history. And I said to him, you know, we are going to do further investigations. We will do the genetic testing. And it came back negative. And we did a skin biopsy, came back negative. And with that, I said, you know, I think that you just had a dissection causing your pica cerebellar artery territory infarction, but you do not have CADASIL.
Okay. Thank you, Dr. Biller. It was an excellent, fantastic talk. I think all of us have learned a lot from the talk, and mainly many clinical clues with regard to the diagnosis and management. Thank you.
Thank you very much.